All right. Hi, everyone. Thank you for joining us. My name is Dr. Emily Duggan, and we are pleased that you can join us for this lecture on our fourth volume of our 12-week No Neuropsychology Didactic series that brings you lectures from experts in the field covering different topics each week. The series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. We would like to thank our sponsors for their financial support for the series. And before we start, here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower portion of your screen, and a recording of today's lecture will be provided on our website later this week. All right, now it's my pleasure to introduce Dr. Francesca Arias for today's lecture titled Contextual Factors in Delirium. Dr. Arias earned her doctorate degree in clinical psychology in 2017 from Fordham University and completed her APA-accredited internship at the University of Florida Health Sciences Center with a focus in clinical neuropsychology. Dr. Arias then stayed at the University of Florida Health Sciences Center, where she completed a clinical neuropsychology postdoctoral fellowship with a focus in pain, aging, and cognition. She is currently a clinical neuropsychologist at Beth Israel Deaconess Medical Center, part of Harvard Medical School, and an assistant scientist at the Aging Brain Center at Hebrew Senior Life. Her clinical and research interests center around cognitive aging, particularly health trajectories of older adults, and understanding how chronic medical illnesses interact with acute medical events and socioeconomic factors to precipitate cognitive decline. As a bilingual and bicultural neuropsychologist, Dr. Arias is also interested in systematically examining the cultural and social factors that influence participation in health-seeking and health-promoting behaviors among ethno-racially and socioeconomically marginalized older adults. Dr. Arias is also an active member of the Hispanic Neuropsychological Society. All right, thank you so much for joining us, Dr. Arias. I'll let you share your screen and take it away.
Thank you so much. So is everything okay? Do you guys see my screen fine?
That looks perfect.
Beautiful, okay. So thank you so much, Dr. Duggan or Emily, for inviting me. I really respect everything that you guys have been doing, that No Neuropsychology has been doing for the past 2 years. And I always either try to attend your lectures or definitely I'm one of your frequent flyers on the YouTube channel. So thank you so much for inviting me. So we're going to be talking about contextual level factors and delirium. And this is the focus that has been the focus of my research, the focus of my clinical practice, most of my clinical practice for the past, I would say, 4 or 5 years. And so I am delighted to be chatting about this. Again, my name is Francesca Arias, and I am an assistant scientist at Hebrew Senior Life and a staff neuropsychologist at Beth Israel Deaconess Medical Center. So I want to make some, well, let's see if I can, advance. So some conflict of interest. I don't have any financial disclaimers or disclosures, any financial interests or conflicts to disclose. However, I do have to acknowledge that my personal experience and definitely my cultural background sort of permeate all aspects of my approach to clinical practice and definitely how I answer or I seek to answer research questions. And so therefore, there's definitely a bias introduced by that. And a lot of people have asked me, why are you including this slide? And I don't know, I feel like we tend to want science to be neutral, to be to be neutral, really. And I don't think that there's such thing as neutrality in science as long as it's sort of spearheaded by us humans who are totally and completely biased. So I kind of want to be forthcoming about my biases, and that's why I've included these slides in actually all of my presentations starting in 2018. So we're going to, the agenda for today, we're going to go over, talk a little bit about delirium, talk about the demographic in the US and how that's shifting, and then social determinants of health, but more particularly the contextual level factors, which are kind of sort of underlie under the social determinants of health umbrella. And then I'm going to talk to you a little bit about the way in which I've answered these questions and these the research questions that I've had in the past 4 to 5 years to sort of give you an idea of the work that I've been doing and really hopefully give you ideas of where you can go forward with this research because there's a lot that needs to be done in this area. So, and then we'll open it up for questions, obviously. So what is delirium? And I feel like as clinical neuropsychologists who are very familiar with the DSM, and particularly the neurocognitive disorders, we don't know that much about acute cognitive changes, or at least it was my experience during my graduate training that that wasn't something that was talked about a lot. So according to the criteria by the DSM-5, so you have to have at least a disturbance in attention and awareness, acute onset and fluctuating. So in disturbance in attention qualifies anything that is related to inability or difficulties sustaining your attention, directing your attention, or focusing. So think of attention in the broader way in which us neuropsychologists tend to assess it, right? So it definitely has to involve a component of attention and also a component of awareness, right? Of lack of confusion or disorientation to time, space, or person. And then it has to have an acute onset. And it's sort of estimated that about within hours to days, you can actually develop delirium or an acute change in cognition. And it has to be fluctuating and it has to be acute. And the most interesting part or the most important part is that it has to represent a change or a shift from the baseline characteristics of the participant. And this is key for the patient. And this is key for those of us working with older adults where other pre-existing conditions may also be present that may be impairing or interfering with cognition. So there also has to be additional impairment or additional disturbances in other cognitive domains. And that can be anything from perceptual, either language or visual. There's also can be issues with comprehension of language, so receptive abilities and expressive abilities as well. And there's also can be some disturbances related to memory or executive functioning, sort of planning and organizing of ideas or behaviors. It has to be, according to me, in order to meet the diagnostic criteria, the disturbances observed in attention, awareness, and cognition cannot be explained by any pre-existing medical or neurological conditions. And so this can become quite a challenge when we're trying to diagnose delirium in the context of dementia. And then the disturbance has to be a direct consequence of another medical condition. And so when we think of delirium, usually, or at least in my training, when I thought of delirium, I thought of it in the context of withdrawal, or I thought of it in the context of in toxicity or intoxication secondary to a substance. But the reality is that delirium can occur, or this acute change in cognition can occur as secondary to multiple etiologies. And we'll talk a little bit about that in the futures and the next slides. So there are two main ways in which delirium may present, or three really, if you think about the mixed. So there may be a predominantly hyperactive presentation, and just like the name suggests, is the one that is related to more to an increase in the level of activity, either cognitive or behaviorally. So you will see agitation, you can see restlessness, you can see diminished cooperation, which can sometimes turn into frank aggressiveness on the part of the patient or participant. There's also tends to be some perceptual disturbances or distortions, either frank hallucinations or some delusions. The hypoactive delirium tends to be, usually it is believed that the hyperactive delirium tends to be most common, but that is actually a myth. And what we've realized is that, at least those of us working clinically and also in delirium research, is that the hypoactive delirium is less likely to be recognized by medical teams. And so therefore is less likely to be diagnosed. And hypoactive delirium, just like the name suggests, is characterized by sort of like a grogginess, or sort of the patient or the person seems lethargic. There's an excess of sleepiness, and seems withdrawn and sort of quote unquote out of it. The reason why I said that this kind of the hyperactive versus hypoactive delirium can create some sort of dichotomy that in reality doesn't exist. And those of us that have seen delirium in clinical practice can say or can tell that patients throughout the course of the condition can fluctuate, and at certain times of the day, or the same patient at certain times of the day may be showing hyperactive signs, and later in the day may show hypoactive, or vice versa. And so therefore the mixed, you actually refer to it as hyperactive dominant or predominant, or hypoactive predominant, to sort of acknowledge that there may be room for some hypoactive features or hyperactive features to emerge, or for or mix. And it's the presentation that where actually both hyperactive signs and hypoactive signs have been documented, or are believed to be present. And so in terms of the prevalence of delirium, so it actually varies by setting in clinical group. And what do I mean by that? So for example, in perioperative settings, in medical settings, it is much more prevalent than in community dwelling individuals. It is also much more prevalent in persons undergoing different types of surgery. It is also prevalent, or most prevalent, in older adults. And in fact, it is believed that up to 30% of hospitalized patients experience delirium during their hospital stay. And that is actually, the number goes up to 50% of patients undergoing any type of hip, who experience hip fracture, or who are undergoing hip replacement surgery. In context of the different settings, it is estimated that about 75% of patients in intensive care unit exhibit some signs of delirium also at any point during their intensive care stay. And so delirium is associated with high medical costs, and this is particularly true for older adults, where it can actually lead to also poor outcomes, poor clinical outcomes. So in terms of healthcare costs, the cumulative costs attributed to delirium alone, so this is independent of other costs related to medication and treatment, but just related to the episode or the delirium condition, the overall cost actually ranges from 34,000 to about 56,000 per patient per year. In older adults in particular, delirium has been associated with poor clinical outcomes, and anything from prolonged hospitalizations, discharge to a care facility as opposed to discharge to a home environment, and definitely increased mortality and increased risk for long-term cognitive decline. And the asterisk sort of shows that these are two of the risks, or two of the outcomes that are most common among older adults. So delirium is also, ironically, is highly preventable, and highly preventable by actually making very sort of small, I should say, changes to the healthcare. So things like streamlining medications, or incorporating some behavioral or even physiological changes, so increasing hydration, decreasing anemia. All of those things can actually decrease the prevalence of delirium. And in fact, up to 30% of the delirium that is detected in medical settings could have been prevented. So even though it is highly preventable, it's a preventable condition and it's also highly treatable, unfortunately, it is underdiagnosed across all medical settings. So not just inpatient or intensive care units, but also even in outpatient kind of procedures or surgeries. So why delirium? Why does it matter in the context of the US population? And I think that this is where my work and my personal interest sort of came in. So I cared about delirium because it's so prevalent and because it allowed me or gave me an opportunity to really intervene and shift somebody's or a patient's cognitive trajectories. And as a neuropsychologist, with the set of tools that I possess, I kind of wanted to be able to not just assess and establish a baseline, but sort of be able to maintain and help improve. I also was interested in working with older adults, not only because of my own experience with my father, personal experiences with my father and my grandmother, but also because the changing of the population. So we know that persons over the age of 65 years are bound to the prevalence or the demographic characteristics of the US landscape is sort of changing. It is estimated that by 2060 we'll have about 98 million older adults or persons over the age of 65 in the United States. This is not only happening to those among the older than 65, but the concept of the super agers or people over the age of 85 are also going to the number of people over the age of 85 are also going to increase exponentially here in the US. There's also going to be shifts in the distribution of women to men. Meaning we've already started seeing these trends, and that the majority of persons over the age of 65 are going to self-identify as women, or are likely to self-identify as women. And this brings in their own challenges related to the rates of poverty of older women, their role as caregivers, so the level of responsibilities within the family structures that sort of adds a layer of complexity to our role as caregivers for these future patients. Also, place of residency is also going to matter, and the majority of patients over the age of 65 actually are non-institutionalized, at least in the US, and those about 30% or less than 30% of those who are non-institutionalized also live independently. So not only I think are they at high risk of, let's say, falls or vulnerabilities, I mean, socially and economically, but also the idea that they're going to be slightly disconnected from medical care, medical systems. And so that's going to mean an increased need for caregiving. And I show some numbers here and about how that is going to change and how that's going to shift based on the age or the estimated age of the patient group. And so with this increase in the representation of persons over the age of 65 in the US, we are also going to see a shift in the representation of diverse, linguistically, culturally, and socioeconomically diversity in the US. And so this graph speaks volumes. And so we see how the red line, which is our non-Hispanic white individuals, the overall number is going to decrease, and Hispanic and other racial minority groups are going to become or are going to represent the main demographic engine of the population in the near future. And so this is the most significant demographic change Americans will see, many of us in our lifetime. And so when anytime we talk about our desire to work with diverse groups, our desire to work with not just age diverse, but also linguistically and socioeconomically and culturally diverse, we must think about what are the contextual level factors? What are those environmental built environment characteristics that sort of influence and impact everything from their lives, their ability to engage with healthcare providers and the healthcare system. And so we think of social determinants of health, and I feel like this is a buzzword that has been around, or buzz construct that's been around for the past, I don't know, 10, 15 years, really. It's coming from the World Health Organizations and their efforts to sort of understand what are some of the factors that are non-individual or patient-related factors that influence health outcomes. And these factors include lifetime experiences, socioeconomic status, healthcare quality and access, social capital, which meaning social networks social networks and reliance on community partnership and community support, and the built environment. So in our research, or in the research that I'm going to be presenting, when I talk about contextual level factors, I'm really talking about the social determinants of health that are mostly related to socioeconomic status, either presently or across the lifespan, by measuring and assessing childhood SES. I'm also talking about the built environment when I talk about contextual level factors, meaning the deprivation of the neighborhood, the walkability of the neighborhood, the availability of community organizations, health community organizations, but just in general, other resources. So I want you to keep that in mind, because I'm not broadly talking about just social determinants, but I'm really talking about these very specific factors, which is what I've tried to quantify and really study in my research. Globally, though, social determinants of health in general, so the umbrella term, has been associated with clinical outcomes. It's been implicated in obesity research, in diabetes work, and we've identified individual level factors such as like health-related behaviors, right, as instrumental to patient well-being, to longevity, and just overall health. And contextual level factors, we've identified things like neighborhood characteristics, or like I mentioned earlier, access to healthcare in the sense of community agencies and community support that the patient can turn to in case they have questions related to their health. And in this graph right here, Livingston et al., it's just a beautiful graph, because it's one of the studies that has most successfully made the case for the relevance of both a life course approach as well as or social determinants of health, and in the context of cognitive health. And this has been done in the context of cognition more than anything. And we see here throughout the lifespan, and this is a graph that has been presented, I think I've seen it in like 5 presentations already. If you went to AAIC, you probably have seen this figure quite a lot. And so we look at how early life exposures in terms of like reduce or level of education, and then exposures throughout the lifespan, explain about some of the risk, about 40% of the risk associated with developing long-term cognitive decline. Two things are particularly relevant to the work, our discussion today, is number one, there's about 60% of that risk that's unknown. So there's room for a lot of us to be working collaboratively to really identify and increase what we know can be prevented, or how we can prevent dementia or neurocognitive disorders. So that's number one, which makes me excited as a researcher, that there's a lot to be known and there's a lot of opportunities for growth in this area. But also, what's particularly relevant to me as a delirium researcher is that this has been done in the context of acute cognitive changes. And so it has been a journey of trying to apply for grants and submit proposals, and then submit manuscripts, because people are like, well, I see the value of it in terms of dementia, but why is this relevant to delirium? And if we think of the brain as the one organ that's sort of orchestrating everything, I mean, sorry to cardiologists and all the other specialists, but so if we think of the brain as an important organ in terms of orchestrating health, particularly cognitive health, then we have to think about, well, why isn't acute cognition? Why aren't we doing this work in terms of acute cognition, particularly if experiencing an acute cognitive change sort of predisposes you then for long-term cognitive decline. So technically it's in the pathway to long-term health, cognitive health. So those are the two main takeaways from this point. And then I want to anchor this discussion, and which has the framework I have used to anchor my work in the Hills et al. Model for NIA for health disparity framework. We look at so the many factors. It's a highly theoretical model, and so therefore applying it in research, applying it or operationally quantifying it has been a challenge. However, it is quite comprehensive, and it offers us and it's quite in tune with social challenges experienced by so many of our patients and potential participants. So it focuses on the fundamental factors of disparities and sort of labels them as such, and then tries to organize them across different levels, and sort of recognizing a life course perspective sort of peppers everything that we do across the lifespan. So when we talk about life course, we don't only talk about our experiences in childhood, but we also think about what are the exposures that we experience in midlife, what are the stressors or the potential protective, how much exercise and how much water were we drinking during midlife that can be protective or that can be deleterious. So let's delve into the research in the work that I've been doing for the past few years. So this started at the University of Florida as a postdoctoral fellow with Dr. Catherine Price and the group at the Perioperative Cognitive Anesthesia Network. And basically Beacon, I was one of the first graduates of the program, and I think I saw a few of you, I think Kat is here, a few of you are sort of coming from this lab in this work, in perioperative work. And so basically it's a tripartite model, if you will, including clinical, education, and research. And so there, the focus of my research was to really highlight the value of neuropsychology in terms of not only the value to our colleagues in perioperative settings, so other stakeholders such as anesthesiologists and surgeons and geriatricians and primary care providers, but also to the patients themselves. And this is where the disparity flavor, the sort of empowerment of patient for me was relevant. And so as part of the Beacon protocol, we completed a brief and abbreviated about 30-minute neuropsychological screener. And so the first work that you're going to see, the first studies that I conducted were really surrounded the issues that I brought up before. So the value of neuropsychology to patients and informed decision making, and the value of neuropsychology to our colleagues. And so the first few papers, our first paper was really based on a case study, trying to identify the relevance to informed decision making for family and caregivers. And this was a case study of a 70-year-old patient that was referred through the perioperative clinic for a quite an outpatient procedure, but for him it's actually going to be more of an inpatient, but what seemed like a very straightforward procedure that had in the past with this patient being associated with prolonged hospitalization and discharge to rehabilitation. And so the patient had a few vulnerabilities, including age, which is one of the #1 predictors for delirium, but also a prior history of aggression and sort of dysregulation, behavioral dysregulation in combativeness in the context of prior surgeries. There were also issues related to CAD, so some cardiovascular risk factors, as well as some pulmonary and renal risk factors and renal insufficiency. The patient had been evaluated previously, and the baseline was diagnosed with a mild cognitive impairment. And this was a full neuropsychological evaluation that was conducted. And here are some of the evaluation and some of the results. The highlight of this case is that we didn't capture severe or really statistically significant only across two tests, but we didn't, or two domains, if you will, but we didn't capture severe cognitive insufficiencies from one testing to the next, which was about 1.5 years later. So the testing with the full neuropsychological evaluation versus the one conducted as part of the perioperative assessment that's conducted at the University of Florida. But what's most important actually about this patient is that our intervention or our feedback to surgeons, anesthesiologists, and the family itself influence their decisions, clinical treatment, as well as the family's decision to proceed with treatment and surgery. So it's explicitly, really, the patient actually decided and actually was on board with doing prehabilitation, where his medical care and medications were streamlined. And he agreed that prior to surgery, he was going to work with occupational health and physical therapy to actually improve his mobility, reduce some of the weight prior to undergoing surgery. The treatment team, anesthesiologists, surgeons, were actually on board with this. And this actually was one of the first patients that benefited tremendously from perioperative and the opportunity to actually continue monitoring. And then he postponed the surgery for a year or so after this intervention. So our second research or manuscript that came out of that experience at UF, or the work at UF, focus on the role and the value of neuropsychology in the context of perioperative settings. And so we know, and has been well established, and actually by Dr. Catherine Price and some of the professionals, some of the research coming out from Duke University, about the role of neuropsychology and cognition in major cardiac surgeries in general. However, the role of neuropsychology in the context of outpatient surgeries had not been quite established. And so we collaborated with our colleagues from gastroenterology to examine the quality of colon prep prior to a colonoscopy. And so we know, or many people don't know, but for detection of unsatisfactory or poor quality preparation or bowel prep, it's being associated with poor detection of colon abnormalities, premature discontinuation of procedures, and then a need for repeat assessment, sort of creating a backlog and creating a backlog within the medical system. So it's kind of an inefficiency as part of the system. Factors associated with inadequate bowel prep prior to our research were the presence of health conditions like cardiovascular risk factors such as diabetes or hypertension, and poor health literacy. And this is related because a lot of patients don't understand what it's required of them and how involved and how to the T the instructions for quality preparation must be followed. However, how cognition influences quality of prep had not been previously studied. And so our first aim was to examine that association between general cognitive status and quality of bowel prep, and the association between psychiatric neurocognitive diagnosis and then quality of bowel prep. I'm not going to go into too much detail about how we operationalize bowel prep, but we use the Boston bowel prep score, and the higher the score, the better the prep. And so part of our results, so there's some demographic characteristics of our sample, which was quite small, but then we assess cognition just at at baseline to sort of make sure that we were in that a simple cognitive test or a simple screener would have given us the answer. And so what you see here, what I'm really focusing your attention is that there were no difference. So based on cognitive score or an MMSC of 24, was not successful at capturing any significant difference in the way people prepare for quality for their bowel procedure or their bowel prep score. However, if you look at when the data was actually examined by a clinical neuropsychologist, so blinded to patients' demographic characteristics and previous diagnoses, either psychiatric, pain, or cognitive diagnoses, the being labeled as major neurocognitive disorder by a clinician or being assigned that diagnosis was actually significantly associated with reduced quality prep, in that those that were considered to have major neurocognitive disorder were actually much more likely to not only present for their appointment with poor bowel prep, but also more likely to actually miss their appointments. And so, based on this experience at the University of Florida, the treatment team actually modified their patient care. So gastroenterology incorporated some prehabilitation type of workups. So that included cognitive assessment or a brief cognitive screening, not really a full neuropsych assessment, but a 30 to 40-minute protocol. And more importantly, those patients that were identified as having vulnerabilities, so psychiatric, particularly depression, as well as major neurocognitive disorder, were then funneled into a kind of a more titrated type of care, where they actually receive support by a volunteer at the university to sort of walk them through some of the bowel preparations and identify caregivers and family members who could support them in the bowel preparation process. And so, again, very translational efforts and very translational a use of the results found in research. So after the University of Florida, I transitioned to the Hebrew Senior Life and BIDMC, or Beth Israel, here in Boston, where the focus has been predominantly on sort of bringing in some of the skills in the findings of or the results that we published at UF. And so studies 3, 4, and 5 have really focused on developing the understanding and the operationalization, really, of social determinants of health in the context of delirium. So the pros and cons are that we at Hebrew Senior Life been able to sort of work with a well-characterized cohort, the SAGES cohort, that has been, followed for over 11 years, really, at the at Hebrew Senior Life by Dr. Sharon Enoye and her team. And so our first paper was really looking at environmental or the built environment, talking about or looking at the characteristics of the neighborhood and the level of disadvantage of a neighborhood, and how that predicted delirium, not only delirium incidence, but also delirium severity. Our additional works have also revolved around predictors of caregiver burden, so social capital, characteristics of the caregiving environment, so in the home environment. So are these patients residing independently? Are patients residing with a child or a paid caregiver? And how does that influence not only caregiver burden, but also patient-related or clinical outcomes? And I am very ecstatic to report that this paper, A Framework of Social Determinants of Health, just got published today, so really hot off the press, looking at and proposing a framework for social determinants of health in the context of delirium that is tailored to older adults. So let's talk a little bit about the first study that we did at UF, which was really catapulted subsequent grant applications that I've submitted and I've been awarded, and that really is going to inform the rest of my career. So we looked at, we know that delirium is highly prevalent, and I made a case for that earlier during this presentation. We also know that factors such as intoxication. I talked a little bit about my previous experience with delirium. So prior to my fellowship at UF. So we know that intoxication, depression have been associated with delirium. Age, frailty, and cognitive impairment are also associated with delirium. However, how social determinants of health or contextual level factors is really my favorite way to conceptualize this variable or built environment. How that's associated with delirium have not been quite as investigated. And so what we did is I quantified ADI, or area deprivation index, in 560 older adults who have been followed through the SAGES cohort. And the ADI is kind of a marker of neighborhood level social disadvantage. And it uses about 17 markers of neighborhood characteristics, and you have everything from availability of phone lines within a census block to number of persons of single head of households within the given block. So it uses kind of census data to sort of update its equations and its algorithms. So it ranges from 1 to 100, so the ADI, and higher values indicate greater socioeconomic disadvantage at the level of the neighborhood. So again, this is independent, or sort of independent, from the patient's own income. So this is kind of labeling and quantifying the level of access to resources, or one way of quantifying access to resources within a given neighborhood. And the delirium was assessed using the CAM, which is one of the, actually the most well-established tool to assess or to identify delirium incidence. And also we assessed the severity using the CAM as well. So what did we find in our paper? So number one, ADI was significantly associated and linearly associated with severity as assessed by the CAM. But just I want to highlight that the distribution of the patient population in the SAGES cohort, if you see, the neighborhood is kind of in the low disadvantage area. And this is not only a product of the SAGES cohort alone, but also representative of the Massachusetts area and where the patients and participants were recruited. That is Massachusetts, because of the nature of the state, actually ranks higher than a lot of the states, particularly those in the Midwest, in terms of the ADI, the area deprivation index in the nation. And so regardless of that, and knowing the limitations of our cohort in the data, we found a linear association and a significant association between area deprivation index and delirium severity. And we also found that when compared to other risk factors, in talking about a contextual level, but also individual level factors, risk factors for delirium, we found that ADI, or being in the most deprived, living in the most deprived neighborhoods, was actually associated, was actually a huge risk factor for delirium. So obviously, I also want to point out differences in terms of the N and the representation of the groups that were those that were in the highly marginalized area versus those that weren't in the highly marginalized areas. So, so that was one of the first studies. The second study that we published was a collaboration with Dr. Tabulowski in the nursing school at Boston College. And really, we tried to examine the association between patient factors and patient caregiver relationships, basically living arrangements, and the burden of that related to delirium. And if you look at our model, our conceptual model, really it's quite, I want to say, simplistic. So it's an oversimplification. So by no means is this a DAG, but it's just kind of a guiding model that sort of informed the way in which we conceptualize this association in our hypotheses. And so a lot of the information, and in fact, previous work from our group, we have identified how patient factors are associated with caregiver burden. So the burden that caregivers report related to delirium alone. And then, but little is known about caregiver factors or those determinants related to the patient, the caregiver network. So in terms of relationship, but also whether they are residing in the same home or not. And our N was 207, so this was not the SAGES cohort, but this was the Better Assessment of Illness study. And this is a cohort of hospitalized older adults who are a little bit more vulnerable, and also a little bit in terms of their cognitive status than the SAGES cohort, and also a little bit more diverse in terms of their ethno-racial and social and socioeconomic status. And so we actually found that residing, so the majority of caregivers were female and were married, and 47% of respondents were living with the patient, and delirium occurred in about 22% of the sample. We actually found that really more than the caregiver characteristics, it was really some of the patient factors related to functional ADLs that predicted that association between perceived burden by the caregivers as opposed to, above and beyond the characteristics of the caregivers themselves. We also did find some sort of association between child and child-in-law, in that when it was a child taking care of the patient, the scores, the caregiver burden scores, actually were much significantly higher when the caregivers was a spouse. And we put forth several hypotheses as to why we thought this was the case, particularly because we believe that caregivers are actually have been in the patient's lives and witnessing the decline or trajectories much more than the children and the children-in-law. And when the children-in-law step in to sort of care for their loved ones, they're actually come with a reality, face the reality of the level of decrement and the level of help needed for the patient or the participant. So I'm going to be mindful of the time and move a little bit faster. And so one of our latest publications, which is actually under review currently in the Annals of Epidemiology, where we are actually examine how early life exposures are associated with delirium risk. And this was part of this work, the pilot part of this work, which is what I'm talking about today, was presented at AAIC this year. And we know that childhood socioeconomic status has been associated with musculoskeletal disease, diabetes, and even premature mortality. And so in the SAGES cohort, we actually examine how parental education, both maternal and paternal, were associated with delirium incidence and delirium severity. And so we actually, similar to what we found with the ADI, we found a significant association, and we found that paternal education, not maternal, was a robust predictor for delirium incidence. And I want to make sure that you're aware that this, even though this is a sample of 549, the proportion of the variance really explained by our model was very small. So even though it is a robust predictor that sort of stood the test of time, or not really time, but adding other predictors that have been associated with delirium, it's still the proportion of the variance explained by these factors, or the model, the full model really is about 10%. And in the subsequent studies, or actually in that same study, parental education was also significant. Paternal education was also significantly associated with delirium severity. And so I'm going to wrap it up because I feel like I've rambled a lot, but this is kind of the topic that I love. And I kind of want to challenge us as clinical neuropsychologists trainees, or even social scientists to really think of all the ways in which social, environmental, basically contextual level factors can influence cognition at different stages in the trajectory, really cognitive health. Um, these factors are not deleterious necessarily. They can be protective and can be deleterious. And more importantly, if we really think of them across the life course, different factors can be protective and deleterious at different time points. So I think that that's important to sort of keep in mind. There may be benefits associated with considering these contextual level factors in planning medical treatment and follow-up for, and this is particularly the case for older adults. And there might be options to optimize cognitive function to behavioral interventions, and even do some work at the policy level to raise awareness about how these things actually can interact or uniquely affect cognition. And there's also opportunities to tailor medical treatment to consider individual and contextual level factors. So let's think of these demographic, social, economic characteristics when we're developing our recommendations, when we're developing these hypotheses or these proposals for grants, and how to like quantify them and assess them in a way that promotes inclusivity. So there are definitely unique opportunities for clinical neuropsychologists to, number one, evaluate baseline characteristic, which is so important in the context of delirium, because remember, if we don't establish a change from baseline or an acute change from baseline, then we can't really diagnose delirium, and we will be doing what most of us in medical settings are doing, which is really missing this condition that can put some of our most vulnerable patients at higher risk or increased risk of, it can be potentially fatal for some of them. And definitely provide psychoeducation to patients and treatment teams about the risk or the factors or the social and environmental level factors that can be modified to improve outcomes. I think that for neuropsychologists, there's also an opportunity to develop interventions modules, if you will, in this area. And this is something that I'm hoping to get my research. I'm hoping to be the next, I don't know, 5-10 years of my work, working to sort of develop some modules or of interventions. There we have also an awareness about the barriers to participation or access to treatment that are not really related to individual level, right, or the patient's experience or historical factors, but really more related to access, right? If it's going to take me 45 minutes to get to an appointment or to get to a research study, I don't want to participate. And maybe these social determinants of health and these contextual level factors may be also contributing to the issues of representativeness in research. So I thank you all. I'm sorry that I rambled if I did, but I definitely want to thank everybody and then maybe open it up for questions.
Thank you so much, Dr. Arias. I just have to say that this is one of the most wonderful kind of clinically driven, well, research driven clinical talks that I've seen. And I think for our trainees who are watching a talk like this, you also kind of, not to put you on the spot, but you really serve as a wonderful model of how early career individuals can kind of build their work over time and create for themselves an area of research and a plan of research that they can then expand on. And really, I think the things that probably will resonate a lot with people as they're watching this presentation are kind of the way that you kind of so easily go back and forth between tying things to clinical relevance and then digging a little deeper. for things. And so, with that in mind, I think, knowing that some of our viewership is, newer to neuropsychology, um, and since you are such an expert on delirium, might you have just a few words to say about, if somebody does recover from delirium? Because at the end, you were kind of alluding to, this is a risk for even death. But if someone does recover from delirium, what are we looking at in terms of their long term functioning over time? And how is this kind of floating in the back of your head also in terms of your research questions?
Well, I mean, thank you so much, Emily. You guys do have done so much that it's totally a compliment that you think that this was engaging. So I appreciate it. So it's definitely, I feel like more than as a researcher, this question lingers with me as a clinician. To be, if I'm very honest. So I feel like this is why the work that I hope to be doing and the levels of interventions that I hope to be targeting in the next phase of my career are going to focus on prehabilitation. I'm going to focus on preventing delirium, right? Because what we are doing as we prevent is we're potentially changing and shifting cognitive trajectories. But for those of us who unfortunately get to see the patients once they've already experienced delirium, we can expect, or at least for the literature, we have found that there's an accelerated course towards a neurocognitive decline. So if there was a pre-existing vulnerability, the course of that decline is much more accelerated relative to peers. And so that's something to be mindful of. It's something to, and in that sense, in terms of recommendations, so monitoring. So for example, for patients during my clinical practice, if I was seeing them every 2 years or every 18 months, then I kind of bring that timeline a little bit closer to like the 12 month. I want to see you every year until we really clear. We know that at least from the SAGES data that's coming out in this, I think one of the papers was just published like last week or something like that. The data that's coming out says that we do stabilize. So think of delirium and experiencing delirium condition as you would think about TBI. So there's a timeline where after the insult, there's a period of vulnerability where you see some steep decline and then it kind of plateaus, right? You gain some of that back and then you plateau. And so so you would expect that by the 12 month, whatever, cognitive profile you're capturing would be one that is going to be a little bit more stable than the one and actually closer to the person's actual functioning than the one you capture immediately after surgery, right? So make sure that you, as when you're making those decisions related to clinical care, that you're sort of saying, okay, so if you just came out of the hospital last month, makes sense that you're a little loopy or that this is not your true baseline. So let's see you back in 6 months, give you some time to stabilize and then follow you annually right after, right? And so also education with families, right, as to what to expect and how behavioral interventions and behavioral changes in the home, so hydration, physical activity, streamlining of medications, engagement, sensory engagement, so music, art, all these things that we usually recommend to most of our patients are going to be particularly protective for patients who have had delirium.
Amazing. And going back to kind of your main point and your passion of prehabilitation, I'm just so thrilled that you were talking about this and really highlighting the utility of these assessments and the actual prehabilitation itself. And I wonder if you could just, I think a lot of times we think of neuropsychology as most working in tandem with psychiatry or neurology, but this really highlights that there's a place for neuropsychology in so many other areas of medicine. And so maybe you could just briefly speak to other ways or other areas where you think this type of work would, benefit most, so our trainees know to be on the lookout for opportunities in those areas down the road.
So definitely anesthesiology was an ally to, am I answering your question? So in terms of specialty and places where
Yeah.
Emily, is that?
Yeah.
Yeah. So definitely anesthesiology was an ally this has been an ally to Dr. Catherine Price, for example, at the University of Florida, who's my mentor, and has been an ally to me here at BI. So anesthesia has been a partners because they're pretty much invested in optimal outcomes, right? And so it's very much influential to their bottom line, right? And I feel like we actually complement each other well in terms of specialties, because so to them the perioperative context is what's important, and to us we want to see the patient before and after long term. And so I feel like as disciplines we sort of coexist really well. I've also found that surgery has also been quite receptive, that in particular, so for example cardiovascular surgery, and there's a lot of people doing great work in this area. Organ transplants. So these kinds of transplant teams have been quite a place for clinical neuropsychologists who are interested in this intersection, right? And then ultimately, I also feel like for those of us interested in long-term outcomes and even prehabilitation, I want to encourage you guys to seek opportunities in prehab medicine, in rehabilitation and physical medicines, which have also been quite supporters of this kind of work.
Wonderful. Well, I'm mindful of the time. So we're just past the hour. I appreciate so much all that you're doing to champion research in this area and your clinical contributions, and taking time from your busy schedule to present with us today. Thank you again so much. And we look forward to seeing everyone next week for another great talk.
Thank you so much. Take care. Bye-bye.